Good morning, everyone. Today in pediatrics, we are going to talk about respiratory diseases or respirology um, related to pediatrics. Just for the introduction, many things which we have covered, for example, in infectious diseases, you have covered pneumonia or, uh, for example, you have covered asthma in internal medicine, right? So, most of the pediatric things, of course, the diseases are same. So, they will be same in pediatrics just with few differences in management or like if I will talk about pneumonia, so for example the pathogens will be different, right? um, so the good thing, like in ENT we have covered this nasal cavity anatomy, we had covered pharyngitis or tonsillitis, um, we had covered this eustachian tube and what is the difference between the eustachian tube of the babies and the adults. Like this one is more straight and short, and that's why there is more otitis media. Now, in respiration or in respiratory diseases, one of a very important thing is uh, you must know what is the function of that, and we use a word called as or a term called as respiratory distress, right? So refer back to my neonatology section, and you will find I already talk about this one. Do you know what is respiratory distress? Cyanosis, nasal flaring, grunting, tachypnea, wheezing, stridor, chest wall retractions. So the thing is, for example, if I will take dyspnea, for example, dyspnea, of course, which is uh, a shortness of breath, or you can say hunger of for the air. You will find that, of course, an infant cannot complain of that, but a baby or a child who is a little elder, of course, like they can just talk about that or complain of that. And as you know, like dyspnea have different causes, like it could be pulmonary causes, could be cardiac causes, could be other causes, like uh, in pulmonary causes it could be upper airway tract conditions, lower airway tract conditions, or pleural conditions. So simply there are different causes for that. um, Now, um, okay, and then there are, you know uh, much of them, we have explained, but here I want to talk about stridor. Is a high pitched sound which can be heard without any using any stethoscope, whereas wheezing, okay, and stridor occur mostly due to upper respiratory tract like trachea, larynx things, right? But in wheezing, these are the whistling sounds which come from the lungs, and most of the time to hear wheezing, you have to use the stethoscope. Otherwise, sometimes, like in asthmatic patients, like you can hear the wheezing without using stethoscope, but not all the times. Okay, so now uh, uh, see this one. Now, respiratory disorders could be infections like pneumonia, croup, could be foreign bodies, could be congenital disorders like cystic fibrosis, could be allergical condition like asthma, and could be others which are very, very, very uncommon. Um, I would like to start my discussion with this thing. Okay, and in this one, uh, sorry, I want to start my discussion with this one. So, see how I'm going. This one is a child with stridor. As I told you, stridor. Uh, Stridor is like most of the time it is inspiratory stridor. Like when the child is taking doing inspiration, so there you will hear that sound. Okay, we call it as inspiratory stridor. Now the important thing over here is how I am going to take you in this lecture is, see, first of all, we are discussing stridor, right? And stridor is a feature, or it's a sign which we get when there is any upper respiratory tract problem. Okay, one of the sign you can say, not like there could be hoarseness, there could be suprasternal retractions, things like this, right? Now what I want to mention here is, for example, you can see over here clinical features to access, like for like whenever you got a patient with stridor, always look for the fever, look for the hoarseness or barking sound, always look for uh, cyanosis, always check the oxygen saturation. Okay, then you will see, check if the, of course, like this thing you will check the first, like the general appearance, either the child is sick looking, toxic look is there or not, right? Level of consciousness. Then either there is any drooling saliva. Now see, drooling saliva, what is drooling saliva? Of course, when someone is having drooling saliva, it means that there is a blockage and they cannot uh, take the saliva in, right? So that's why the saliva is coming out from the mouth. And check for the stridor, chest recessions, like mild when it is just present at the rest, right? Or it could be um, severe when there is, even at the rest there is what you can say chest retractions, right? So simply, now why I'm talking in this way, because these are the clinical features you are going to check. And in pediatrics, history, uh, you will take from the caretaker, and the history is always like, you can say some typical questions which you have to ask, like to look out if there is any um, um, you can say fatal condition, right? Or to see, like for example, when the fever started, for how long is their fever, right? So simply just to you can say think, either the patient, either the baby have any infection or source of infection you can found. Okay, uh, now for example, whenever any child will come with stridors, hoarseness, or suprasternal retraction, so basically the disease is above the thoracic inlet. Above the thoracic inlet means what? It's an upper respiratory tract problem. So now there could be many causes of that thing. For example, it could be croup. Like I will discuss in a while what is croup, right? It could be bacterial tracheitis, croup, bacterial tracheitis. It could be epiglottitis. It could be a foreign body. It could be a subglottic stenosis, like congenital, for example. It could be laryngomalacia or tracheomalacia, right? Which is like collapse of the airway cartilage on inspiration. right? Things like this. Now, what's the point of taking you guys in this one? Uh, is see, whenever the baby will come, you will take the history, you will do the examination. Examination points I told you. History points, now you have to think either it's a croup, it's a epiglottitis, it's a bacterial tracheitis, whatever is this. And before that, based on the history and examination, you have to think either it's an emergency or not. For example, um, stridor, stridor at rest is an emergency. Drooling saliva, it's an emergency. Chest recessions, which are present even at the rest, are is if not emergency, but you can say one of the thing on which we decide and we admit the patients in the hospitals, right? So you can see like we can go in this way, right? Now uh, I will talk about Croup, for example. Okay. Okay. By the way, guys, I am just saying the things, but in this slide, all of the things are present, right? You can see like when you will get the slide, uh, all the things are explained over here, right? So don't think like I'm just saying and not writing the things, but uh, they are written over here. Okay, the slide. Okay, now croup is also called as laryngeotracheobronchitis, like the inflammation of the larynx, the trachea, and the bronchus, right? But it's like you can see like this croup. Okay, now this croup is common in children who are less than 6 years of age. By the way, here it is written 6 months to 6 years of age. But most commonly, you will find children around 3 years of age or less than that, right? Now, it is very common in fall and early winter. Most of the time, this is caused by the croup. Croup is caused by para-influenza virus. This is the most common cause. Para-influenza virus, right? Now, this para-influenza virus causes around 75% of the time croup. Okay. Now, it could be caused by influenza, influenza A, influenza B, respiratory syncytial virus, which is also called as RSV. And how it present, like basically, because it's a viral, mostly viral, so the child they present with rhinorrhea or running nose, with pharyngitis, cough, with or without fever. So whenever there is fever, of course, like the fever is very low grade. But one thing which is very typical of this thing is what, like they present with harsh barking cough. And in many of the stations, like in PLAB and AMC, what they do, like they show you a dummy, and once like you will start taking the history from the dummy, from the role player, the dummy will cough. Okay, and you have to catch from that cough, how the cough looks like. So it is worse at night, so it disturbs the parents and the baby a lot, and the stridor is also there. Okay, so of course, like mostly it's a clinical diagnosis, but even if you will go for a chest x-ray, like sometimes you can found a steeple sign, steeple, steeple sign. Okay, so steeple sign is basically subglottic narrowing. So this is about croup. Okay, and what we do, by the way, how we manage croup is like as I told you, like we evaluate clinically either the baby needed any admission or not. So, for example, if there is a toxic looking child, the level of consciousness is gone, drooling saliva, and in this case particularly, if you will found that the stridor is present at rest, it is a medical emergency, put them in the hospital, and what to do, just give them dexamethasone per oral, one dose. And if you think like there is too much upper airway compromise, give them epinephrine nebulized form. In nebulizer we give them epinephrine. Okay, in very severe cases of course you can intubate them, but like that is seldom needed. So this is about Croup, right? Now, if you found a child who is very toxic looking, okay, who looks in distress, who have stridor, who have sternal recessions, who have very high grade fever and drooling saliva, it is epiglottitis, guys, until proven otherwise. By the way, nowadays it is very rare. So most of the time you will found in the children who don't get vaccinated. Why? Because we nowadays give vaccinations against human influenza virus B. So that's why the incidence is decreasing in children. Okay. Now, if you know like H influenza, so here is the positive organism as well. A toxic looking baby, remember 4 Ds. 1 D is drooling, second D is dysphagia, third D is dysphonia. So you eat, you speak from the same thing, right? And 4D is distress. So remember, drooling of saliva, dysphagia, dysphonia, and the one who is looking in distress. And you will find that the child will be having a loud stridor, and the child most of the time will be in a tripod position. Tripod position, if you can see that, that tripod on which we fix the cameras. So, guys, it is a bacterial infection mostly caused by H influenza type B or beta hemolytic streptococcus. Okay, it is rare since HIV immunization. Okay, and it is basically supraglottic laryngitis. Okay, and see the name epiglottitis. The epiglottis is inflamed. So when the epiglottis is inflamed, so it will compromise the airways simply, right? It is clinical diagnosis, guys. It is clinical diagnosis. Don't examine their throat. It is very, very, very important. Don't examine their throat, because if you will examine their throat, maybe you will further exacerbate the you can say the obstruction. The muscles can go into spasm and the child can die. So simply the treatment is in emergencies, like just to quickly decrease inflammation, you can use nebulized epinephrine, number one, but mostly we intubate them, we start them on antibiotics, okay, to treat this thing. Bacterial tracheitis. Now see, croup is basically subglottic laryngitis. This one is supraglottic laryngitis. Bacterial tracheitis is subglottic. Supraglottic, okay, this one is supraglottic, this is subglottic, and this is subglottic. Now, guys, this is subglottic laryngitis, this is subglottic tracheitis. Okay, bacterial tracheitis is rare, okay, and it can affect any of the age group. So, as you can see, like it is bacterial, so it is caused by H influenza, hemolytic streptococci, pneumococcus, and things like this. And it presents same like croup. There is no difference. Just the difference is this is viral, this is bacterial. This one have low grade fever, this one have high grade fever. The child here is not so much toxic looking here, they are toxic looking. Okay. So this one, of course, is bacterial. If you will treat it like croup, it will not respond. Why? Because they need antibiotics simply. So this is about bacterial tracheitis. Inhale foreign body, of course, like you will get a history like this. Of course, the child will be having no fever, okay, and you will get a clear-cut history of ingestion, or you can see it on X-rays, right? And laryngomalacia or congenital airway abnormalities, there are many types, and these are mostly surgical cases, right? So this is how we approach the baby of upper respiratory tract infection, or a baby of with stridor or hoarseness or cough or anything like this, right? Okay, so like you can see, like the things are, you can say, if you will go by this way, things systemically, you can make the concept, right? And how, what to see on examination, what to ask on history, and all this stuff. Then comes a infant with tachypnea or wheezing. Okay. Now, very easy way by guys see. Tachypnea is increased breathing rate and wheezing, as I told you before, right? Wheezing, um, you can say, uh, they are the sounds which look like whistling, okay? Whistling sounds. And whenever there is too much wind, it's too much windy, and your uh, windows are closed, sometimes you hear the whistling. So that's more like wheezing. Okay. Now, why we hear that whistling when our windows are closed and there is too much windy? Now, see, this is like a very good way to make the concept. See, guys, it is too much windy. The air is trying to pass through the small areas around your windows. So that's why they make this whistling sound. And wheezing is simply when the airways are constricted, your airways are constricted and the air try to pass through them. And remember, that's the reason, what is the condition which causes airway constriction? Asthma, right? So asthma give recurrent wheezing, or you can say, whenever anyone will ask you what is the differential diagnosis of wheezing, think about asthma, bronchiolitis, foreign bodies, pneumonia, right? Cystic fibrosis, things like this, right? Okay, guys, now uh, I will talk about, now because as we are talking about tachypnea or wheezing, okay, so you can see like what clinical features you have to notice here, and then we will talk about the things and you would understand like what's going on. So now we are basically, what we are discussing is lower respiratory tract infection. Number one point is this thing should be clear. Second thing, like lower respiratory tract infections are those which occur due to, or lower respiratory tract abnormalities or pathologies or whatever diseases are those which occur when there is the problem is below the thoracic inlet. Whenever the child comes, check their level of consciousness, check their fever, ask about any weight loss, exhaustion, apnea, check for cyanosis, check for hepatomegaly, okay, because cardiac failure is one of the cause. Check the oxygen saturation. Of course, like when you will go systemically, it will be like this: level of consciousness. Then you will take the vitals. Then you will go for GPE. You will notice the cyanosis. Now, see, heart rate is important. Breathing, true breathless to feed. Respiratory rate greater than 40 means tachypnea. Chest hyperexpressions, chest recessions, use of accessory muscles, expiratory grunting, nasal flaring, auscultation, percussion, any abnormal signs. So these are the things you will see. Now, if you have done your diagnostic in a good way, I think like you would understand what different signs means. Okay, guys, see. Any child who come to the hospital, okay, who come to the hospital. So again, I want to mention, like, guys, see, in this slide, you will find pneumonia, okay, you found bronchiolitis, everything is written, right? Even you found asthma. But as I like, of course, like all the things which are written in the books, and if I will keep on reading them, they're of no use. So I'm giving you more conceptual game. Okay, so first of the thing you will found is bronchiolitis, right? See, all the things which we have examined and all the history points which we got after talking to the parents, we have to fix those pieces or clues together and make the differential diagnosis or diagnosis. So bronchiolitis is basically a lower respiratory tract infection, usually occur in children less than 2 years of age, most of the time from age 1 month to 9 months. And this bronchiolitis is the most common lower respiratory tract infections in infants. So it also comes in winter or early spring, and the children who have bronchiolitis, they have increased chances of getting asthma later in their life. Now guys, one thing to remember about bronchiolitis is what? It is caused by RSV virus most of the time. More than 50% of the time it is RSV virus, respiratory syncytial virus, RSV. RSV, respiratory syncytial virus, this one. Of course, like there could be other viruses like influenza, parainfluenza, adenovirus, rhinovirus, and XYZ, whatever. But most of the time it is caused by RSV. Okay. So, okay, by the way, like when I was studying these things in medical school, I always confuse either it's parainfluenza, which causes bronchiolitis, or Croup, or it's RSV, which is the most common cause of bronchiolitis with Croup. So I make the concept like this, where Baskin Robbins is the very famous worldwide ice cream brand. So I remember it by Baskin Robbins, BR. So respiratory syncytial virus, bronchiolitis, right? Okay, now how they present, like basically they present with, like it's a viral infection, they present with runny eyes, runny nose, things like this, with cough, rhinorrhea, a little fever, difficult feeding, all the things which you have done before. But basically they have wheezing, they have crackles, they have respiratory distress, they have tachypnea, they have tachycardia, they have retractions, and all these things. So you can see over here, chest retractions, hyperinflammation of the chest, inflation of the chest, fine and inspiratory crackles, wheezing, liver displays downwards, not so commonly, but okay, and things like this, right? Now guys, again it's a clinical diagnosis, but if you will go for an x-ray, you will find maybe atelectasis and peribronchial thickening, things like this. You can do a nasopharyngeal swab to check for the viral antigen. WBC is most of the time normal. Now, how we treat this condition? Like it's a self-limiting condition. It's a self-limiting condition. So the symptoms, uh, they peak, or you can say like the condition of the baby become peak after 3 to 4 days, and like most of the viral illness, it resolves within 10 to 15 days, you can say. So the only thing we have to decide is the clinical condition of the patient, either the baby need hospitalization or not. So when the disease is mild to moderate, uh, what is mild to moderate, and how we decide like if it's a mild to moderate condition? Basically, what we do, uh, we simply check like either the baby have what you can say cyanosis, oxygen saturation is dropping, decreased air entry is there, use of accessory muscles is there, expiratory grunting, nasal flaring, and all these things if they are present, they're like they cannot feed and all this stuff. So it is characterized by as severe condition. So mild to moderate condition, again supportive treatment is needed, per oral or IV hydration. If there is fever, give antipyretics, and sometimes we can give them humidified high flow oxygen. But in severe condition, we hospitalize them, and then we check depending on the condition of the baby. We think like either we have to admit them or not, or sorry, we have to intubate them or not. Okay, and in very few cases or high risk cases, we can give antiretroviral drugs, but most of the time not needed. Okay, so guys, nowadays like there is uh, what you can say, there is RSV immunoglobulins are also available, which can be given, and it protect against this severe condition. So now, of course, it's a viral cause mostly, so antibiotics won't help in this one. So any patient who will present with bronchiolitis and you found like his oxygen saturation is dropping, he have tachypnea, he have any comorbidity like lung disease or cardiac disease, or if the child is less than 6 months of age, just admit them. Okay, so this is bronchiolitis. Okay, regarding pneumonia, guys, it will be same. There is no difference what you have covered, right? The only difference is, wait, I will show you now here. Pneumonia. I'm just telling you the differences, guys. Okay, okay. Here the thing is written very generalized thing. I can tell you few of the things to remember will make your life easy. Okay, causes of pneumonia. Okay, because we are studying from pediatrics, guys. In the neonates, remember one thing: the most common bacterial causes GBS, uh, group B streptococcus, right, or E. coli, okay, or Listeria. Now, see, these are the organisms which they can contract while passing through the vagina. That's the only reason. In 1 to 3 months of baby, the story changes like this way, that the most common become Streptococcus aureus, okay, then H. influenza, and then Streptococcus pneumonia, which is generally the most common cause of pneumonia. Okay, and basically after that time, it's same like adults, being the Streptococcus pneumonia the most common cause, right? And if we will talk about the viral causes, the most common cause in the neonates is CMV. Okay, it is CMV, and after that, respiratory syncytial virus. But okay, most of the time, of course, the viral questions are not asked. You can just remember these things. Okay, guys, rest. There is no difference. There is no difference at all. If you have done pneumonia, done. Everything is same. Okay, but remember, in regarding pneumonia in children, viral causes are the most common causes. By the way, nowadays, the world is revolving around pneumonia. So see fever, poor feeding, cough, lethargy, cyanosis, tachypnea, nasal flaring. You'll find the same things, guys. We go for chest X-ray, we give antibiotics, and all this stuff. So you have done this thing, pneumonia. So there is no difference, what you have done. There is no difference in this one. Okay, guys. So transient early wheezing with viral infection, risk increase in preterm and maternal smoking. It's transient. It goes away by itself. Non-ectopic wheezing following viral lower respiratory tract infections. Anyone who will have bronchiolitis later on, they will having this thing, which will go away. Asthma, I'm going to discuss in a while. Cardiac failure can also give tachypnea or wheezing, or inhaled foreign body. Of course, you will get in the history the point, right? So that's all is same. Nothing is different. Okay. And one of the things which I wanted to talk about, not in too much detail, is uh, asthma. Sorry, I'm going like this way so I can quickly jump on asthma. So childhood asthma, childhood asthma is the same thing what you have covered in adult asthma. Simply, um, in the history you will found the same things like uh, the extrinsic causes, the intrinsic factors. The extrinsic causes like upper respiratory tract infections, smoking, cold air, exercise, whatever you have remember about the asthma. And the intrinsic factors, again, there is some genetic predisposition and the families where there is what you can say history of allergies. Okay, so like the same thing will be there. Now, guys, like we all know about asthma. What is asthma? It's a reversible constriction of the small airways. We all know that it's a very common condition. We all know that uh, this is a normal airway and this is the airway with asthma. We all know like their airways are hyper responsive to any endogenous or exogenous stimuli. And most of the time when you will found the asthma in any family or in any baby, you will found the history of allergic rhinitis, atopic dermatitis, atopic diseases, urticarias, and things like this, right? A lot of skin allergies, or simply you can remember like the history of allergies will be there, right? Now the triggers will be being the same. Okay, and they will present in the same way with chest tightness, wheezing, and all this stuff. Okay, now uh, the important thing to talk about here is you have done that whatever you have done in the adults, like, and the treatment guidelines, but I just wanted to show you one thing. uh, just give me 1 second, let me open that thing. Okay, like this is the stepwise treatment, right? Given in all the books, guys. Some books it is given in this way, in some books it is given in um, this way, right? Okay, first of all, I wanted to talk about what is the difference between the asthma in the adults and asthma in the children is this thing. Now the children's, they cannot use this inhalers. Why? Because this one needs a coordination between the person who is taking them. Like when you will press the puff, you have to inhale right away, right? But in the children, of course, like we cannot make them to do this thing. So we use this spacer devices. So sometimes, for example, if the child can seal his lips here, so just the spacer device was needed. And of course, we connect the same inhaler behind that. But sometimes, for example, if the child he cannot even seal his lips, then we use spacer with a mask, right? For example, this one. This is see a spacer device with a mask, right? So this is one of the difference you can say. In children, what you must know or what you must educate is like, of course, when we tell them that, okay, it's a reversible condition and they have to take salbutamol, which is called as Ventolin, or they have to use like Atrovent, which is ipratropium bromide, uh, things like this. So we tell them that, okay, uh, like the regular inhalers you have to buy, but you have to buy the spacer devices. You have to divide, like sometimes if the child is too young, so you have to get this mask as well, okay, this thing. And we educate them a lot, the parents, the teachers, the care providers. We tell them, uh, we write a asthma action plan, what to do in this case, what to do in that case. We devise them with exercise programs like swimming, okay, and we tell them all those things, and we tell them, what to do when the child is feeling having these symptoms. And rest is like everything is same, there is no difference rather. uh, but like this stepwise treatment is done in asthmatic patients. Like if there is mild intermittent asthma, so mild asthma is simply asthma in which like there is occasional attacks of wheezing or coughing less than 2 times per week. And whenever they use this inhaled beta 2 agonist like Ventolin or salbutamol, which is salbutamol, they feel good and they never need systemic corticosteroids. And then, for example, if the symptoms are not controlled in this one, we jump up. Okay, not controlled on this one, jump up. Not controlled on this one, jump up. If it is well controlled and there is no symptoms for a long time, jump down like this. So that's why it is called as a stepwise treatment. So anyone who have moderate type of asthma, like you have more frequent episodes with symptoms persisting, and there is chronic cough, there is decreased exercise tolerance, and sometimes they need systemic corticosteroid. We say like their asthma is moderate, and severe asthma is simply when they have daily or symptoms during the night, and you will find them having a lot of emergency visits. They require a lot of hospitalization. They require systemic corticosteroids and all this stuff. So of course, like in them, we jump up, right? Sometimes we put them step 5C, continuous frequent use of oral steroids. Okay, so this is the worst one. So that's all, guys, for respiration. I hope you understand. And after this, like I'm going to talk about the last lecture, that is about rheumatology, and that's it, right? So see you around. Bye.